Today was like any other day. I put on my scrubs and packed the lunch that I will never eat, and I strapped on that badge and the scope again. It's a beautiful day in the city, but I doubt I'll go outside to breathe in any of that air. Many of my patients are suffering. How can I find peace when they are suffering? Sometimes I feel it's important to stay in a difficult situation when someone else is experiencing a challenging one. What I mean by that is I truly have difficulty leaving my patients while they're in the hospital. I particularly find it difficult to give a sign out to another clinician, as it makes me feel like I'm abandoning the patient in some way. We all know that's not true, but I often ruminate over their disease process or something I could have done better to ensure that they have healed or weren't suffering after I left. Luckily, I leave them all in competent hands, the hands of experts who have trained for years in the field and the specialists. I often make sure I get in early the next day to review the patient charts and do a few callbacks to see how those patients were doing. Did Lily's fever go down? Was Jose able to make it to the appointment in the outpatient clinic? Was I able to get one of my patients to the Bridge Clinic to get their methadone set up? Did the patient get to the cath lab and have a return of spontaneous circulation? And will my unopened can of Diet Coke still be in the fridge? But anyway, back to my day. I'm already filled with an intense fear that today is going to be busy. It's Saturday, and there are already a lot of people waiting in line to be registered. I grab a mask and place it over my face. Sometimes I do this to blend in right away. I think we all wear masks in different ways. Mine just happens to be physical. As I walk into the triage bay, I hear the nurses talking to patients. There are about 4 patients all being questioned at once. Some of the things I hear. When did the rash begin? How long have you had trouble breathing? Sorry, sir, we don't have any sandwiches at the moment. Please, if you're going to talk to me like that, I cannot help you with your problem, so please stop cursing at me and take a seat. These are all the kinds of conversations that bleed over into my brain hours after I leave. As emergency medicine clinicians, we have to be trained to deal with the absolute worst and have the absolute best attitude. Today, I plan to have the best attitude because I can see things are pretty grim. I sit down at my desk and sign into the computer and scroll to see how many people are waiting. Currently, there are 38 patients in the waiting room. Our department is completely full, and there are multiple traumas underway. We have admitted 36 patients, and they're all boarding. Several of my patients from yesterday are still here. I can see that many patients that I have treated are back again, even though they've been discharged. Or maybe they never left. I'm not sure what we did or didn't do for them yesterday, or what we're going to do for them different today. But I did hear it was going to rain later. And that means a lot of things for our department. The first couple of patients that I see are what I call easy. That means they have a problem that isn't an emergency, but I can certainly do something for them. I can make something happen. The first gentleman has back pain. I know him quite well because he comes in regularly for his back pain. He is often non-compliant with his treatment regimen, and his issue is often musculoskeletal related. I do my physical exam and ensure that he has no red flags that would alert us to something terrible like a spinal epidural abscess or an aortic aneurysm or something a bit nefarious like a renal stone or acute coronary syndrome. His heart and lungs are clear. He's bending down to show me where his pain is, and then he jumps up and down and says that when he does that, it makes the pain worse. I review the last record and I ask him when the last time it was he took any pain medication. He said he's been out of pain medication for several days, and the only thing that works is oxycodone. In the past, I've tried to have conversations with patients about opioids and their addiction propensity, but today I'm feeling generous. Although the literature does not support giving opioids for musculoskeletal back pain, I think that I can make him happy with giving him 1 tablet and encouraging him to continue his gabapentin and Motrin Tylenol regimen. He seems happy with this plan, and I encourage him to follow up on Monday at our free outpatient clinic on campus. Of course, I tell him to come back if he experiences a fever or any other concerns that may warrant additional workup. He thanked me and it was on to the next. The second patient was experiencing abdominal pain. It was pretty classic for an appendicitis. I love patients who have abdominal pain. However, I don't love the pain they're experiencing. Even less if they're vomiting. Workups for abdominal pain are very straightforward and are often complemented by a CT scan of their abdomen and pelvis with IV contrast. I quickly place the orders for labs and the radiology order, knowing that the patient is going to need it. The right lower quadrant guarding, fever, and diarrhea, as well as colicky pain, remind me of my own appendicitis. Sometimes I feel like my lower abdomen hurts, like a calling sign, when I see someone with right lower quadrant pain, because it just screams appendicitis. I grabbed my side and I took a deep breath after that one. The third patient is not so simple, but I'm not sure I'm going to make anything particularly useful happen. I make my way to the attending pit as their eyes all dart up to me with no head movement. "Hi, Martha. Didn't know you were here this weekend. Nice to see you. How's it looking out in triage?" "Which one of you drank my Diet Coke?" I ask. My eyes go directly toward the physician drinking a Diet Coke. "Oh, not me. I brought this one from home. It was the last one in the pack." "Likely story," I said. "Listen, Doc, I have a patient who's out there who's diabetic, whose blood glucose is reading high. They have polydipsia and polyuria, and they're making me feel like they have DKA, and I was wondering if you have a bed in the recess room that I could place them in immediately so that I don't have to dick around with any potential complication." "Sure, we can get them started in the hallway," the charge nurse then chimes in. Or should I say, the most important person in the room. I mean that lovingly and wholeheartedly because the charge nurse makes my day better. I know that charge nurse is having the worst day ever every day of their life, but for me, their presence truly makes my day the best. I guess that's a good example of making the worst situation positive. The charge nurse goes on to talk about how she's missing her child's soccer game and can't wait till 7 p.m. I pull down my mask, give her a smile and wink, and steal a pen off the desk that I know I'll need later. Before I go back out to the triage bay, I stop in the break room to see if my Diet Coke is actually there. Surprisingly, it is. I crack it open, take a swallow and a breath, and go back to my non-ergomatic friendly chair. At least I'll stay hydrated, even if my wrists are both forming carpal tunnel.